Good morning, everyone, and welcome to our COVID version of Grand Rounds, which is being done virtually. Don't mind the background. I'm not inebriated, and it's too early for me to drink, but the lighting was best in here. In any event, next week we'll have our last of the summer Grand Round speakers, who will be Jonathan Torres from Harvard, who's a kind of leading figure in the area of digital technology and its incorporation into psychiatry. So that'll be very timely because of the fact that in the context of COVID, the field is undergoing a reset with regard to virtual means of telemedicine and also the possible incorporation of digital technology for service delivery. I want to make two announcements before making a couple of comments prior to introducing our speaker today. One is, I have about 10 pages of announcements that I could make on the usual things that we try to announce at rounds in terms of awards, grants, honors, etc. But we've curtailed it for obvious reasons, but there's two that I just can't resist. One is Lisa Dixon was elected to be on the board of directors of the National Alliance of Mental Illness. So, that is the leading advocacy organization for mental illness in the country, very influential. Lisa being elected to it shows the degree of respect and confidence that the advocacy community has in her to want her in that position as somebody who's a provider, but also understands from personal and professional experience what mental illness does to people and families. And the other is continuing our string of, I think it's an unbroken string of every year having at least one person. Joshua Green, PGY2 resident, was selected as an NIMH Outstanding Resident Award. So this is a very prestigious thing, which the NIMH tries to identify and recognize kind of the scientific stars of the future. So congratulations to Josh. I want to just make a couple of comments about COVID. This is something that I can say in retrospect, we met the challenge of, in terms of responding as professionals, as healthcare providers, when this hit and when it surged, and when everybody was tested, even to the point of exceeding human limits, thanks to everyone's participation, not just within our department, within the medical center, within the hospital, within the institute, and the state, and also Governor Cuomo's leadership. New York has weathered the storm and is managing it effectively and successfully. That's the good news. The bad news is that we have to keep doing it because this is not one and done. Plus, our neighboring states, organizations, institutions have not done such a good job. And we see this basically reverberating through the country where hotspots are popping up and creating crises. And it's like a rolling process. And the process, as best the epidemiologists, the infectious disease people can tell us, is one that will continue with maybe some seasonal variation until we have either herd immunity, which we're not anywhere close to, or a vaccine. Now, the herd immunity is something we would only achieve. The threshold that's quoted is 60% of the population. Right now, New York City has a positive test rate of 20%, but the country is under 10%. So we've got a ways to go. A vaccine, the trials from the Moderna US company and the Oxford AstraZeneca UK company are promising. And even if they speed this along at warp speed, the vetting is the first step, but then there's the production of 7 billion doses and the distribution of that in a hopefully equitable process. And it's not clear how long that would take to occur. My best guess is that the process will take us through 2021. So we're looking at another year, at least, of working under unusual conditions. Now, we have, because of the good job that New York has done and we've done with containing the contagion, begun a reactivation of sorts. So clinical care is ongoing, albeit with a substantial portion being done virtually. Research has resumed at the basic science level, and the clinical research programs beginning imminently. But this is being done in a very measured way. It's not just, turning the switch and going full bore. It's a very gentle reactivation, seeing if that results in any adverse consequences, and then increasing it gradually. So we're in this process, and it's one that we're going to have to remain focused and disciplined on. We have to really maximize COVID safety, at the same time try and enable ourselves to be productive in the missions that we're usually engaged in, and the last being education, in which Melissa and her colleagues are determining what the best strategy will be, as is the university as a whole. So we get an A on having dealt with the crisis so far, but this is not something that's going to be a short-term process. It's something that is going to go on, and the analogy that I've used in the past is, and again, it's reflected if anybody's interested in reading an interesting book on it, a book that Eric Larson wrote called The Splendid and the Vile. So the first year of World War II, when England was under air attacks nightly, the Battle of Britain, we're sort of in that kind of situation where there's something hanging over us that we have to contend with on a daily basis. But I know we'll quit ourselves in a very admirable way. And as I see how we're doing it, painful as it is, it makes me ever more proud and grateful for the department that we have, for our faculty, trainees, and staff, and the institutions we're part of. Okay, having said that, it's a real pleasure to introduce our speaker today, who actually has spoken to you and us in earlier COVID-related contexts, Dr. Katherine Shear. Katherine is the Marion E. Kenworthy Professor of Psychiatry in the School of Social Work and the founding director of the Center for Complicated Grief at the Columbia School of Social Work. She's a clinical researcher who first worked in anxiety and depression, and then for the past 2 decades, she's been focused on understanding and treating people who experience persistent, intense grief. In this context, she developed and tested complicated grief therapy, CGT, a short-term targeted intervention, and confirmed its efficacy in 3 large NIMH-funded studies. Kathy received her undergraduate degree at University of Chicago, and then her medical degree from Tufts. She came to New York and did her internship at Mount Sinai, and then internal medicine. And her internal medicine, having started out there myself, was under 2 kind of legendary medicine chairs, Fenton Schaffner and Richard Gorlin. And then she saw the light and decided to retrain in psychiatry, which she did at Cornell, and then remained on faculty at Cornell until she was recruited by David Kupfer to the University of Pittsburgh in 1992, where she remained until 2006, when, I'm ashamed to say this, sort of unbeknownst to us, the School of Social Work offered her this prestigious endowed chair, an opportunity to come to Columbia and New York. And she has been a diamond in the rough, so to speak, because of the fact that she's an extraordinarily researcher and academic, and a talented clinician, and a just gracious individual. And we haven't we haven't bridged the however many blocks it is between the health sciences and the Morningside campus enough, but that now happily is coming to an end as we're going to get as much of her as we can. So because of the fact that Kathy's somebody that needs to become acquainted with as many people in the department as possible for collaborations, interactions, and so forth. And because of the fact that her expertise is so germane to the experience we're going through, we wanted to have her speak in this Grand Rounds series. So it's a pleasure to have her here today, and she'll be speaking about Healing Milestones and Derailers, a guide for understanding grief and promoting adaptation to loss. Kathy?
Thanks so much, Jeff. Let's see here. So I actually changed the title of my talk slightly to talk about bereavement and bereavement in 2020 because of a paper that was published on June 16th, actually, which I'm going to tell you about. But thank you so much for inviting me, and thanks to everyone who's here today. And I want to also acknowledge my close colleague and friend, Dr. Naomi Simon, who I believe is here with us today, and she and I have been working on sort of two different, slightly different, but similar presentations, which for Grand Rounds is she is going to be presenting at NYU in a week or two. So we've been working on this kind of together. So what I'm going to talk about today is I'm going to start with COVID-19 deaths and bereavement because of the paper that I mentioned, which I think is both highly important and highly relevant to all the things you were talking about, Jeff, because even if we were finished with the pandemic itself, we have almost certainly, well, we definitely have a second wave of public health problems, which is the argument that this paper will make that pertain to the bereavement. That's one of the reasons why the paper is so important, but I'll tell you the other in a minute. But then, you know, the issue, one of the issues around grief is that it's so kind of protean in many ways, and it's so unique and individual and private that there are things that you can say that are in common about grief, but the things that one person thinks are the sort of heart of grief are not necessarily what another person does. So we've spent a lot of time in our group and in our larger group trying to understand grief in a meaningful way for for clinical work, really. So I want to talk a little about that, and then also about prolonged grief disorder, which is now in the ICD-11. So it will be, which I believe will be well, it was planned to be implemented in 2022. Of course, even though we're, I guess, not a part of the WHO anymore, I think that's a very important development. And it's the process of moving it from the, what is it, Section 3 of DSM-5 into the main body of the manual is well underway and should probably be completed by early 2021. And I want to tell you just a little bit about that also. And then I want to end with a sort of brief, simple clinician's guide to working with grief, because if you're like me, before I started this work, I didn't realize this until I really tried to get into it directly, but I was actually afraid to work with grief and bereavement. I really didn't feel prepared. I knew that, of course, it was important, but I was, I tended to veer off grief itself. I don't think I understood it either. So I want to provide people in the audience today just a simple way, I think, of working with grief, because I think we're going to be seeing a lot of it. So this is a slide that I'm sure all of us see one version of this or another at least once a week, or maybe even once a day. This came from yesterday. So as of yesterday, global deaths were at 608,386, and 140, a little over 140 of those were, almost 141 were here in the United States. So this is the paper that I mentioned. It was published in PNAS on June 16th, and it's called Tracking the Reach of COVID-19 Kin Loss with what they call a bereavement multiplier. And they make the point, that I made a minute ago that I want to move this. I have to move this away so I can't. Okay, that COVID-19 created a mortality shock, they called it, but it may yield a second wave of population health concerns tied to bereavement and the consequent loss of social support. And in fact, their multiplier shows that the burden of bereavement will be nearly order of magnitude higher than deaths themselves. Okay, let's see. Sorry. So I'm going to show you a few sort of slides from this study. So this is their bereavement multiplier, which they developed by doing something they call demographic microsimulation. And one of the reasons why I sort of emphasizing this is because not only does this give us very important information about our world today and the world of the immediate future, but also, as far as I know, this is the first group that has made any effort, really, scientific effort to try to estimate how many bereaved people there are for every death. So that's important information for us regardless of how people die. So this is a complex mathematical, or it's not so complex mathematically. I would say it's complex demographically and methodologically how they sort of worked with this to come up with these estimates. And they're certainly not firm estimates. They could be smaller than this. They could also be larger than this. But they also did another very interesting thing that you see on this slide, which is they separated their estimates between the black and white people in our population. And what you can see here is that this is where they get the almost tenfold, order of magnitude greater impact of bereavement than death itself. And that's the 8.91 number. And then, of course, we're not surprised to see that the Black participants' overall bereavement multiplier is higher. I'm going to say significantly, though they didn't do statistics on that. And it's down here at the bottom than the white Americans. So this is really, the paper is a call to action because as they point out, having a family member die is tied to all kinds of elevated risks, health risks, physical and mental health decline, and also broader adverse implications for society at large and relationships. And this is all well documented in a rather extensive literature on bereavement. I included at the bottom of the slide a couple of the references that they put in this particular paper, but there's a lot more information than this that validates that statement. And so they also wanted to quantify the bereavement burden in order to focus attention on a potential second wave of population health issues that would be tied to bereavement. So, and one of the important things about this is that the age pattern, as we know for COVID itself, does not look like the graph at the right here. Rather, it is highly skewed to, I forget which way skew is, but it's quite a bit more elevated for the older population. But what you see here is that the bereavement risk is equally high for the population that is 10 to 40 years old. And it's also the Black population actually is the sort of dotted line at the top of the 10 to 40 range, that sort of lighter dotted line, and the white population is the dashed lines, the darker dashed lines. And so you see that it's quite a bit higher again for the young Black population. I think something that is enormously important for public health and for our country at large. Additionally, for a hypothetical 100,000 deaths, this was one of the calculations they did, assuming that 40% of those deaths are white Americans and 60% are Black. That's kind of an a gross oversimplification in a way, but it's a reasonable sort of estimate to work with. You can see how many more, based on these multiplier differences as well, how many more Black Americans, 550,800 compared to 354,000 white bereaved people there. So there's quite a bit more bereavement within the Black population, which of course represents only about 13% of our population. So population-based, overall population-based, that's quite an elevated rate. And they also make the point that in addition to the burden that older adults face from COVID itself, they have a disproportionately higher rate of vulnerability to bereavement. But very importantly, adolescents and younger adults are just as high in terms of their risk of bereavement. And that there is data from the literature, and it makes sense also that this group is especially vulnerable to adverse consequences of bereavement. And again, that's something that's pretty well documented in the literature from other kinds of death, but bereavement has a long-term effect when it occurs during childhood and adolescence.
Kathy, can I just interject just for clarification purposes?
Sure, sure.
Um,
Sorry.
when you're citing these statistics and saying it's reflecting bereavement, I mean, everyone who suffers a loss goes through some type of or level of bereavement. So are you referring to prolonged bereavement or what used to be?
No, this is overall. This is not prolonged
So this
grief
is
disorder.
normative bereavement as well as.
This is the loss of it's actually the loss of a grandparent parent. It's loss of a grandparent parent, spouse, sibling, or child. So that's how they use the demographics of those kinship relationships to calculate these numbers. And they are estimates for sure, but as far as I know, there is no other estimate of bereavement. And actually, in one way, they're an underestimate, especially in the Black population. There are many, many people who experience strong bereavement, strong grief responses after the loss of people who are not blood relatives. And so, so those are not included here at all. It's so, but so we're not talking about how many people have prolonged grief disorder, no, but that it isn't only prolonged grief disorder that produces these adverse consequences. Bereavement itself, we know, is a huge stressor for anybody. Anybody who's experienced it knows that. I was talking to a colleague yesterday we were talking about this, and she said, yeah, she said, I lost my first husband, and I felt like I had really a serious disability for about 6 months or so. She said, I really couldn't function socially almost at all, and I was having trouble just doing things competently. And
So this is a metric that is reflecting, one of the sequelae of the COVID pandemic that extends beyond what people normally think is the sort of usual range
sorry,
of impact.
right, exactly. Exactly, for the whole population. We'll talk about prolonged grief disorder in a minute, um, but then, so I guess this just makes one other point I want to make here that if a million people, I think the numbers for that 60% herd immunity that you mentioned, Jeff, I think the numbers of deaths when there's a 60% herd immunity in the country are going to get up around a million at that point, and that would mean that roughly a third, 3% of all Americans would be bereaved by COVID, which is a huge number, as we know. Okay, so let's talk about grief. As I mentioned earlier, it's universal, but we don't all understand it in the same way. And in particular, there's a way of understanding grief, which is the stages of grief, which was, of course, introduced by Elizabeth Kubler-Ross back in the 1970s, related to dying patients and the grief that she thought that dying patients experienced, which was a huge, had a wonderful and important impact on the field of death and dying and grief. But it's not true of bereavement. It's really a very different situation to be grieving the loss of your own life than it is to be grieving the loss of a loved one. In particular, when you're grieving the loss of your own life, you're going to the same place. Everybody's going to the same place. So there's a certain kind, it's still not uniform, but there's more uniformity in that. Whereas the contributors to grief are so kind of individual and unique and sort of changing that it just doesn't, it's not the way it works. We don't go through denial, anger, bargaining, depression, etc. And the grief field has known this for a long time, but the lay public and actually the rest of medicine seems to hold on to this. So one of the points I want to make today is that there's really no evidence at all, and working clinically, it's something that doesn't help. So there are no predictable stages. Grief is messy. It contains thoughts and feelings and behaviors. Another thing that people sometimes think it's an emotion, but it isn't only an emotion. It has other psychological features, and there's social and spiritual aspects as well. And it's also not one thing. It doesn't sort of, you don't have experience grief and then you have grief for a period of time and it slowly attenuates and then it's sort of resolved. That's not the way it works either. It changes radically and unpredictably, and even after it's what we will call integrated, it will still at certain times kind of increase. It does evolve as we adapt to a change, and it's affected by things around us. It's affected by other people and events that happen. So we're going to say that grief is the response to loss, really writ large. It's a sort of full body response. It's complex. And for a reason that I'll tell you in a minute, we say at the Center for Complicated Grief that grief is the form love takes when someone we love dies, almost kind of literally. It's permanent. It doesn't, I mean, it sort of does get resolved in a way, but it doesn't leave us. It doesn't go away. So we continue to have a response to the people that have died in our lives decades, really probably for the rest of our life. We still have some feelings about it. We still have to think about them. We still have, we're still aware that they are gone and not coming back, etc. So it is universal and there are recognizable features, but it is quite unique to every person, and not only every person, every loss that we experience. So it's not the same for losing, for me, it's not the same if I lose my parent or if I lose my child, obviously, or my spouse. And it naturally contains a lot of mixed feelings and thoughts. So this is something Bowlby points out in the Loss book. It's very interesting. If you don't know it, it's a good read. So I want to say a little bit more about these mixed feelings and confusing thoughts. So we want to often we want to hold on to grief because it feels like the only tie we have in the beginning. It feels like the only tie we have to the person who died, or the most important one. Of course, that's not necessarily true, but in the beginning we do that and we want it to be over at the same time because it is quite painful. But we almost welcome that mental pain while wanting it to go away. We want to go on with our own life. We know we have to go on with our own life, but we don't have much enthusiasm for doing so. And we need other people. We don't grieve well alone, but we have trouble, really trouble feeling connected to them. So we have all of these kind of mixed feelings and confusing thoughts. And so how do we understand all this? And basically, we've taken the position that attachment theory can help us understand it. Of course, I don't have to tell this audience, we have a biological, biobehavioral motivational system that kind of guides us to seek, form, and maintain close relationships, and also actually to adapt to their loss. So these are people, as you know, who are intrinsically rewarding and they serve safe haven and secure base functions. And they do so primarily through the attachment working model, which is something, again, I think everyone in this audience is pretty familiar with. So I won't say too much more about it, except that there's a large literature right now, and I don't have the references listed here because it would take up more than this slide. Every single one of the sort of checked functions in or processes on this slide has at least one study associated with it, and most of them have multiple studies associated with them. So attachment relationships serve as relationship regulators. This is something that Myron Hofer from PI also introduced many moons ago. And I actually have been very interested in this because I worked with him in a postdoc fellowship after I finished my residency at Cornell. But this is very important because the people we love are sort of affecting us. Obviously, we know they affect us deeply, but they're affecting us in a lot of ways you can see here that we're not really that aware of. So in a way, it's not so surprising that they have such an impact. And we know too that the caregiving system is the sort of mirror image, and attachment is also linked to exploration. And so these systems are also going to be very affected when someone dies. So what happens to attachment and exploration um, when this whole system, when someone dies, is on the left-hand side here, but it really translates pretty directly into the symptoms of acute grief, which are listed on the right here. And this is really one of the reasons why we say that grief is literally the form that love takes when someone we love dies. So what do we see though with acute grief? We see intrusive thoughts, strong emotions, grief-related behaviors, and a lot of physical symptoms. This is what's really typical. Now, which exactly ones of these are and how, what the balance is variable. But the other thing that happens when someone close dies is the adaptive system in our brains is triggered, the sort of attachment adaptive system, you might say. And Bowlby called this mourning, actually. He said that the mourning process is automatically triggered when someone we love dies. And it's geared towards basically helping us learn. So we have to learn to accept the reality of the death, which is to accept the finality of the loss and the permanence of grief and the changes that, when someone close dies, it changes the whole world around us. It's in some very mundane, concrete ways often, but also in terms of our social identities and our social roles. And all of that is also very important. And of course, we now have a changed relationship to the person who died. We don't lose our relationship because it's been internalized most of the time anyway, but it is, of course, very changed after they die. We have to find a way to kind of accept that. And you cannot do it sort of 10 minutes after the person died. It's probably physically impossible. So this takes time, and people do it in their own time and in their own way. And that's something that's important to recognize as clinicians. And the second thing we have to do is find a way, we have to learn again to how to restore a sense of well-being, because bereavement really undermines that. And the three things that are listed here on this slide, the restoring of purpose and meaning, that another way of saying that is to restore a sense of autonomy using the self-determination theory that was promoted in the 1980s, I think, by Richard Ryan and Edward Dietschy, who are two psychologists, and that's another sort of framework that's been quite extensively empirically tested and not that well known, starting to make its way into psychology. I don't know about psychiatry, but in psychology, and it does have a lot of relevance. It's mostly been used in the education field, but what they basically said was that in order to have a sense of well-being, we need to have a sense of autonomy, which means basically a sense of purpose and meaning in our life, a sense of competence, and to feel a sense of belonging and mattering in life, which is having meaningful relationships. So grief is transformed as we adapt to loss. Essentially, it becomes integrated. We like to say that grief emerges naturally after someone we love dies, and it finds a place in our life. That's what this really says. So it may be facilitated also by something that Dan Gilbert and Timothy Wilson call a psychological immune system, but which they say are implicit mental mechanisms that protect our psychological well-being in a way somewhat analogous to the way the physical immune system protects our physical well-being. But remember, it's messy. And it turns out that some of the things that are messy about grief can actually derail the process of adapting. And so, and these are some of these, I'll say a little bit more about them, but they're natural. It's important to remember they're not pathological in themselves. They're not, in a way, they're not maladaptive unless they get a foothold, unless they really kind of take over. So, we all hold on for a while to the possibility that our loved one isn't really gone. It's almost something you can't avoid doing, especially if the death occurs suddenly and unexpectedly, as we know many of these COVID deaths really do. Um, we we often do feel anger. We protest the death. We blame ourselves or others. That's just something that almost everyone does, at least fleetingly, um, right after someone we love dies. And we virtually always engage in some counterfactual thinking. We generate imagined alternatives to a situation, to any situation, actually, when goals are blocked. And this is another area where there's a large body of research by our psychological colleagues. Um, and it's quite adaptive to do this under many circumstances. However, in bereavement, when a bereaved person gets kind of caught up in these imaginal situations, this is the if onlys. People sometimes, if only the doctor had diagnosed this problem earlier, maybe we would have been able, he would have been able to be treated, or if only they hadn't gone out to see another friend that night in a car, they wouldn't have gotten into the car accident. Almost any death can have counterfactuals, and so we do naturally imagine them, but most of us will just understand that there's not a lot of mileage in that and kind of set them aside. But sometimes people can't do that, and um, that will block adaptation. And the other thing that is also very natural and almost universal, and this is Stephen Hayes, which I'm sure you're all familiar with, and John Bowlby's work, that we all do these things. But when avoidance becomes excessive, and really the only way that a person has of managing the emotional pain that's naturally associated with grief, that again can derail the process of adaptation. And that's really what happens with the syndrome we've been calling complicated grief. The field called complicated grief when we entered it, and we sort of stuck with that for a variety of reasons. But now the diagnostic gurus in the world have decided that prolonged grief disorder is a better name, and that may well be true. And these are the ICD-11 guidelines. They don't have criteria, as you may know, but these are guidelines for the diagnosis. And basically, what they're saying is what really matters here is the persistent and pervasive grief, which is at the heart of grief is longing and yearning and preoccupation with the person who died. So there's some combination of that just is it's almost as though the person just died yesterday. People we see often say that, or last week, or very recently. And it should also be accompanied by intense emotional pain, which it virtually always is, and persist for an abnormally long period of time, which there's still some debate about what that period of time should be, and probably it's variable for different people and in different contexts, but this is what ICD-11 says. And then the DSM-5 new provisional criteria, which are still on the website. I think they are being slightly modified based on a period of public comment, but this is kind of the gist of them, and they are more specific criteria, as you see here, but they match well the ICD-11 guidelines. So we've applied both of them to our clinical data set, and we've also applied them in collaboration with our colleague Stephen Koza from the university, the Uniformed Services University, who Steve did a large family bereavement study a number of years ago, and he applied these criteria to those data, and basically they produce similar results very similar to our clinical sample, and also they're very similar whether they use ICD-11 or these DSM-5 criteria. So there's one other point I want to make, which is that there are risk factors that can increase the chances really that those derailers will kind of take over, will get a foothold, will get traction. And that then really increases the risk of PGD. So these are person related. Some of them are person related. Some of them have to do with the relationship, the type of relationship with the person who died. And you'll notice that what's not on here is an ambivalent relationship with that person. We think that we've seen very few people who had an ambivalent relationship. Occasionally that is true. It's not like that doesn't happen, but it by far the most common kind of relationship is an identity finding, a very strong identity defining relationship, often a sort of attachment security perspective. It's a secure relationship in a context of a sort of overall insecurity. So someone who will rate as attachment insecure in a general attachment security measure will still have reported a secure relationship with the person who died. And we can talk more about that if you're interested. But in any case, the other thing that's important is a whole range of circumstances related to the death. And that's often what people think about when they think about complicated grief. They think about what was complicated about the event of the death. And that does matter. So let's talk about that with respect to COVID. The kinds of things that are circumstances of COVID's death that will almost certainly increase the risk of PGD. And we're seeing this a lot in the literature now, in both the media and in the professional literature, that the fact that these deaths are essentially sudden and unexpected, seemingly preventable, seemingly random because we don't always know who's going to die and who's not going to die, and then the whole physical distancing problem, all of that around the death itself is going to almost certainly increase the likelihood that people will get caught up in one of those derailers, the counterfactual thinking, the the anger, the bitterness, one of those kinds of things. And then the context of the death, of the bereavement, it should say really, the physical distancing that affects funerals, burials, the rituals afterwards, the support of the grievers, and then also, in addition, the many losses that are accompanying COVID that are not bereavement, the unemployment worries and financial insecurities that many people are experiencing, all the different stressors that are connected with those COVID-related losses that are not non-death losses, and then also the feeling of unsafety that many people are feeling in an ongoing way. And then being alone may happen after such a death, feeling more unsafe because you've been exposed to someone, experiencing multiple losses of people. And this has been happening definitely in the Black community, that many people have lost more than one relative and also close friends. And then having others to care for and the financial worries, all of this kind of conspires to almost certainly increase the rates of prolonged grief disorder, which I didn't mention, but they're thought to be, for a natural death, non-COVID related, around 7% of all of those bereaved people that Jeff was asking about earlier would be expected to experience prolonged grief disorder. But that number is probably at least doubled by the kinds of experiences that are associated with COVID. So we're up probably around 15 to 20% of deaths that occur with COVID. So this is what we focused our complicated grief treatment that Jeff mentioned on, and we developed this in the late 1990s, early 2000s, and conducted 3 different NIMH studies, and with a total of 641 bereaved participants. And overall, and these studies, by the way, were always, we always compared CGT to a treatment for depression. It was IPT in 2 of our studies and citalopram in the 3rd study. So this is more kind of important evidence that grief and depression are not the same, and that's a very important distinction for clinicians. And you can see here that that the response rates were pretty uniform across these 3 studies and quite high for CGT, especially for a psychotherapy study. And these active controls were, for a 44% response rate to depression treatments is not very good, right? So this is from our most recent study, which Naomi, who I mentioned, we've been working together on all of this. Was one of the PIs of. We had 395 people in that study. And this is the citalopram study, and you can see that citalopram did not beat placebo by very much. It's not a statistically significant difference. And there was virtually no difference between adding placebo or citalopram to CGT. That was kind of a surprise to us. We also have looked at a whole range of moderator variables, which I'm not going to get into right now, but violent death and natural death, we have the virtually the identical response rates. Older adults compared to the whole sample. One of our studies was focused on older adults. In that study, we had people from 55, not really older, but anyway, 55 to I think 90 something, and the mean age was around 66. And we've done one analysis from our first study, which we did in Pittsburgh. There's a published paper by Mario Cruz showing no difference in outcome in the Black population we recruited there, which was about 20% of our sample in Pittsburgh. And this is the remaining 59 individuals who participated in either our older adult study or the multi-site study I just showed you. And you can see it's only about 10% of our sample, which is really too low. That's one of the problems here. But the response rate to CGT did not differ by race, and I think that's important to know as well. So, what is the guide to working with bereaved people? I'm going to end with this and maybe hopefully have time for questions. So first of all, active empathic listening is the bedrock, and that's of course something all clinicians do naturally. Non-judgmental empathic acceptance. So you don't want to be trying to assess, is this grief pathological or not? Is what this person experiencing something I have to change? You really want to help people accept grief and accept the painful emotions. I mean, it's really that's really a lot of what this whole process of helping bereaved people is about. And also you need to kind of you want to be sort of more real in a sense, more a real person. We all experience grief and bereavement, of course, and so being cognizant of that, both in terms of what it means for your own self-care, but also what it means in terms of kind of being bearing witness to the loss and the pain, which is such a human experience. That's really the most important thing to do in working with people. Basically, not to try to do too much, but I am going to suggest some gentle guidance that you can do. But along the lines of the non-judgmental acceptance, one of the things that can happen sometimes during the pandemic or some other situations is that people may need to sideline their grief, to sort of set it aside because of a pressing need to either take care of themselves or others, or because they don't get enough support right now. And people often can do that. I mean, remember, avoidance of grief, actually, and avoidance of triggers is one of the natural sort of aspects of acute grief. And we do worry about it becoming too excessive, but there are circumstances in which it's kind of okay to at least delay the process of grieving. And so, kind of pushing people to go too fast or too far may not be the right thing. This is very individual, but something to keep in mind. Helping people find a balance of allowing some grief and then taking care of themselves. It's going to be unique. And so really what you're doing is you're kind of stepping in as an attachment figure. We do that a lot in psychotherapy. Again, this is not something unique to grief at all, but it's a good idea to think about it in the grief situation. And and also to be attentive and responsive to ruptures. One way to think about ruptures that can happen with grieving people that's a little bit different is that acute grief is almost certainly associated with a kind of temporary state of insecure attachment. In a way, it's by definition insecure attachment. That's what I was showing you a few slides ago of the reaction of the attachment system to acute loss of the attachment relationship. And when we have acute attachment insecurity, we often are cautious about closeness with anyone else. So we tend to feel kind of that sense of disconnection, which is very painful, but also pretty universal in acute grief, and it will stay there when we're talking about prolonged grief disorder too. So you can get a kind of hypersensitivity that's not personality based, but rather situational, and you just want to be able to manage that. And we're going to do personalized interventions based in this, this basically active listening stance. And again, something that I think pretty much all psychotherapists, all good psychotherapists do. We're going to personalize our interventions, and we're going to validate a lot. We're going to do a lot of validating in grief because people often worry about whether what they're experiencing is normal, whether what's the right way to grieve. I get a lot of calls about that. Am I grieving right? I just want to, I'm managing okay, but I just want to make sure I'm doing it right. And so one of the answers to that is, yes, you're doing it right without even hearing what it is you're doing, because grief is what it is, and we want people to understand that. And then we're going to be supportive. And we're also, though, going to make judicious use of suggestions, do some psychoeducation, and sometimes express our own opinions in a sort of, if you're familiar with the motivational interviewing, I think most people are, but it's in an MI kind of way. Can I tell you, would you like to hear how I see this? I might see this a little differently than you do. And we do it that way. So the guidance is based on basically a model that we're now calling healing milestones. This is really, these map on, the healing milestones map onto 7 themes, which are connected with 7 specific procedures, each one connected with a specific procedure, which define the therapy intervention that is CGT. But we've recently decided to kind of try to get this out there in a more user-friendly way, and this, I think, is one possibility for doing that. So basically, what we're saying is that we want to help people look for ways to honor their loved one and themselves, but in particular, by exploring their own interests and values, like kind of reconnecting with their own autonomous intrinsic interests in self-determination theory language. We want to help them embrace emotions, not try to get rid of them or push them away or judge them. And that includes pleasant emotions, which are also very natural during a grieving period, because it's very natural to oscillate between confronting the pain and setting it aside. In fact, that's probably the best way for people to kind of move through grief, is sort of dosing themselves. That's, again, comes directly from Bowlby, if you're interested. People also need to find different ways to manage emotions, to regulate emotional pain, which many people, kind of know how to do that, and they do it pretty naturally. They get thrown off for a little while, but they kind of bring that skill online. But people who have trouble may need some help with emotion regulation. What I've been saying over and over: accepting grief and letting it find a place in your life, living with reminders, so people will, again, try to avoid reminders, situations that are reminders that the person is gone and not coming back, because that's so painful. But we want to, but those same reminders contain some of the really wonderful memories that people really want to have. And so they need to learn, we all need to learn how to live with those reminders, partly because we don't want our lives to be restricted, and partly because we want to have access to the memories that are contained in them. And then we want to be able to integrate those memories into our life and in ways that can help us learn and grow. We know that there is sort of post-traumatic growth has been documented after bereavement, similar to trauma experiences. We want we need to be able to narrate a story of the death that kind of makes sense. We need to be able to think about the death. We sometimes say in doing CGT, we tell the patients we're working with that we want to make the unthinkable, the death of their loved one, which is unthinkable, we want to make it thinkable because it's a natural part of life. And in order to be able to live with the loss of a loved one, we sort of have to be able to think about their death and how they died. And you could even say that to not do so is in a way dishonoring the person because for all of us, death is an intrinsic part of our lives. So the way that we're going to encourage people to do this is by developing a narrative, telling that the story of that death, telling it to themselves, writing it to themselves, sharing it with you, sharing it with other people. Again, something that we all do very naturally most of the time, but people who are struggling may have difficulty with that. And clinicians often are kind of afraid to ask people to tell them the story of the death. And so I would encourage you not to be afraid of that and to sort of be able to bear witness to it. You don't have to change it. You don't have to do anything. Just listen, and in an accepting, empathic way. And then the last thing, gather others around. We sometimes call this strengthening relationships, but again, remember that acute attachment insecurity makes people cautious about letting other people in their life. And actually, it's also difficult for virtually all adults and maybe children too to put themselves in a vulnerable position. Nobody wants to be the helpee. Everyone wants to be the helper. It's much more comfortable for all of us to be helped than to be vulnerable and need the help of others. That's a whole other discussion, a longer one. And keeping in mind as you listen these derailers, and this is just using the derailers as an acronym, and I'm not going to walk through, we've talked about all of these already, but you want to have them kind of in your mind, because when you hear a lot of any of these, you want to kind of focus a little attention on that. You don't have to do formal cognitive therapy. Some people do like to do that. That could be helpful, but you can also just gently um, sort of work with helping the person come to some other alternative ways of thinking about this, or set these aside, or resolve these problems. Actually, I had a conversation recently with the director of a large bereavement facility in Baltimore, and she was saying that she thinks in her work with bereaved people, these are often opportunities for learning, and I think that's a very nice way of thinking about it. It's that if you treat derailers as opportunities for learning, you can learn about yourself, you can learn about your relationship with the person who died, but you want to deal with them in some way. So just a few more comments about the ways to do this, or that what goes into. So accepting grief and letting it find a place in your life. Remember that it's natural. It's a form of love. Don't judge it. You can monitor it. I'll show you that in just a minute. You can get the patient to monitor it, and observe the thoughts and feelings that go along with sort of grief spikes. Um, that when you want to recognize those derailers but not judge them, and you want to allow grief to kind of come and go. Just let it be. So you want to allow it to come. That's what we've been talking about. But you also want to allow it to go, which survivor guilt sometimes makes that difficult, or other, sort of judging ideas about grief can make that difficult. It's also important for grief to be able to recede at times, and we want people to embrace their emotions and to explore their own interests. So embrace their emotions, both the painful ones and the pleasant ones. And the pleasant ones, can connect up with starting to move forward in a way that's kind of authentic for yourself, that does actually have positives in it. And we actually encourage people to build something pleasant. Just, it can be some very simple thing. It can be sitting in the garden for a half an hour, reading a favorite book, taking a walk in the park, or going window shopping. Maybe not during COVID, but whatever. Um, but to do something pleasant every day is a good idea. And then really just start to try to think about what's important or meaningful or interesting. And survivor guilt, we think, might be especially pronounced after a COVID death. We really need to deal with survivor guilt. That's the feeling, of course, that you shouldn't enjoy your life or have positive things in your life because the person who died can't do that anymore. So we use a grief monitoring form like this. Very, very simple. You can do this in 5 minutes at the end of each day. You look back over the day, you get the person to look back over the day, identify at a time when their grief was at its highest level and rate that on a 0 to 10 scale and make a brief note about what was happening at the time, then do the lowest grief and what was happening at the time for that, and then kind of step back and take a big picture overall level. Is it, was it a high grief day, a medium grief day, or a low grief day? And people, they don't, nobody says, oh, I don't know why I didn't think of doing this. I mean, people push back on a lot of this stuff, but once they start doing it, most people find this is surprisingly interesting and helpful. We want to encourage, strengthen relationships, encourage creative ways to stay connected with friends and family, even during the physical distancing, encourage people to talk about the deceased person with loved ones or friends, nurture the social connections in whatever way, and sort of gently help people allow others in, keeping in mind that it's painful, but expectations for reciprocity don't work, because it's really not it's not possible for someone experiencing intense acute grief to be there so well for other people. Again, narrating the story of the death, not to be afraid to do that. And lastly, living with reminders and allowing them to be bittersweet and integrating those memories into the person's life. So understanding that this is possible and that it over time, the person can discover meaningful and comforting memories. And you can kind of do this again in a dosing kind of way, but keeping in mind that this is the direction you really want to go. So in summary, what I've said is that grief is a natural reaction that emerges quite naturally after an important loss and finds a place in our life if we let it. So we adapt naturally, and it's important not to be judgmental. It's important also to seek and savor those positive feelings. Supportive companions are important. And just a reminder again that the COVID deaths might have elements that make this especially challenging. So I will end with this Helen Keller quote, which I think is wonderful. And thank you for your attention.
Thank you, Kathy. That was really marvelous and so relevant and made me wonder. Sounds a little glib, but funeral homes should hand out, descriptions of all of these derailers and coping strategies and informational points. This kind of knowledge should be integrated into our society in the way that our society kind of instructs people in personal physical hygiene. There should be, sort of similar kind of guidance you don't have to go seek out. It's made available to you in some way.
That's a great idea, Jeff. I mean, certainly this is what we think. We think it's a better model than stages of grief. I mean, and people do really need some kind of framework. It's just because it's a kind of experience for anyone who's experienced. I mean, I think any of us who've experienced grief know that it's kind of different than almost anything else we experience in our lives.
So some questions have come in, and for people who are listening, if you want to ask a question, either put it in the chat box or send an email to me. I think it's to me, and then Iris will monitor it. So when a family member dies, what can you say about the interplay between the grief of multiple remaining family members?
Well, the main thing you can say is that they're not going to be on the same page. And so it's a really great question, because it's one of the things that can cause problems. For example, let's say, actually, I'm thinking of someone that once told me that her husband died and she had 2 or 3 sons, I think, and they would, they would get in. They had a lot of problems because on one day, one of them would want to be looking at pictures. They would want to put all the pictures on the walls. They would want to have all the pictures on the walls, and someone else would want to be taking down all the pictures. They didn't want to look at the pictures. And, they had to kind of negotiate. That's another thing that you have to kind of negotiate. And sometimes what can happen, Jeff, is that the person can think that their way of grieving is the right way to grieve. So, the person who is sort of more wanting to really connect with those emotions and process the emotions can be very resentful of the person who wants to avoid the emotions and vice versa. And so they get into fights over who's grieving right. So that's one of the reasons why we want to make sure that there is no right. You really need to respect the other persons and in the family, and often you have to do some negotiating around that. And one other thing is, if your family member is your, generally speaking, your sort of primary confidant, that family member may not be able to be your primary confidant for the bereavement because they're experiencing the same thing. So you may have to go outside of the family to have a close confidant, and hopefully you can do that because, and that doesn't mean that there's something wrong with your relationship.
Another question, Kathy, is can you, if you have somebody who's at a slow decline or is in a terminal phase of illness, can you begin the grieving before they pass?
Yeah, I mean, I think there's pretty good evidence that you can do that. It's a little bit hard because, um, you don't really want to. It feels bad to people sometimes to really think, okay, I know this person is dying. I'm going to have to deal with that, but I think you can do that, and it's a good idea to kind of keep that reality in mind. I think it does help afterwards, but you know, you you're still going to grieve when the person is actually gone. So you can't do all the grieving ahead of time.
Right. Simon, I see that some people are raising their hand. I don't know if we're activating that so they can speak or not. So let me know if you can. In the meantime, let me ask a couple of other questions that have come in. Um, there are different kinds of loss that people experience. So, we're talking about here in the context of COVID, loss of people through illness. But, loss could also be a divorce, could be a job loss, and so forth. And these elicit different reactions. They're admixtures of, sadness, anger, anxiety, and so forth. Is the grieving process attached to each of these, and how does it differ if it is or doesn't?
So there's a lot less known about this, but what we do know is that you can experience the symptoms of acute grief and prolonged grief disorder with other losses. I mean, one example of that is after Katrina, um, there um, there was an epidemiologic study that um, of people who survived Katrina, and many of them had losses. And what we found was that um, that um, people who had had losses other than death losses, there were a lot more people who had lost, for example, their home, who had been separated from family members, those kinds of losses, lost their jobs, and they had a much lower rate of what we then called complicated grief, but there were so many more of them that actually, that was a larger group of people who actually had prolonged grief disorder after Katrina, for example. And there are other examples of this throughout the literature at this point. What hasn't been done is treatment studies of those people. So I would guess that they would respond to a very similar kind of approach to the one that I sort of loosely described today. But we have to see. And the one thing about that is that when you say anxiety, depression, that people, anger, whatever, people experience all sorts of reactions. Those are all part of grief. So if what they're feeling angry about is the loss of their job, or what they're feeling angry about is, if it's all focused on the loss, and if they're yearning and longing is at the heart of grief. So if it's yearning and longing with this kind of array of symptoms around it, then it's probably grief, and it would probably make sense to treat it as such.
So this is going to be a little difficult. I'm going to sort of go out on a limb and say your response may indicate it's a derailer. But so if loss occurs in the context of COVID, how do you deal with the anger towards the government because of, for mismanaging the situation so poorly and being part responsible?
Right. So what I would say about that is that is a reality of COVID for all of us, and so it will increase the chances that that anger gets center stage, and then it is a derailer, and you kind of have to deal with it. So you have to decide how you're going to deal with a realistic situation. I mean, is true medical malpractice, for example, sometimes, or there's true blame, there's true responsibility for someone's death, and you do have to deal with that. It's not that you don't deal with it. It becomes a derailer if you don't deal with it, and it just keeps, it just center stage in your mind, and all you think about all the time is, if only the stupid government had had done the right thing, maybe this person wouldn't have died. So you have to come to terms with. I like to use the Serenity Prayer as a sort of overarching guide, because it really says we need to figure out what we can do something about and what we can't, and kind of focus our attention on doing the things and paying attention to the things that we might be able to do something about. Otherwise, we're pretty much spinning our wheels.
Right, right. So I think Ian Canino is raising his hand. If you want to ask a question, Ian, you got to respond to Simon. In the meantime, let me ask another question. So um, how would you characterize so what would you say is the goal, the purpose? So the grieving is really an ingrained or an inherent psychological program or psychophysiological program you go through with loss, because it occurs, through certainly in mammals and maybe in others, animal kingdom phyla. Um, what would you say the purpose of grief is?
I guess I see it as as a natural response to the loss of someone, or could be something that is hugely important to ourselves, to our sort of, that was the regulatory slide I showed. You're going to lose an input into regulation of all kinds of psychological and biological functions. So what's going to happen? You're going to react. It's a reaction. So it doesn't exactly have a purpose. It is just it's a natural reaction. It's kind of like the pain that you experience if you cut yourself. It doesn't exactly have I guess it has the purpose of not making you could say, making you not want to confront whatever you did to cut yourself. But other than that,
So
it's
it's like Gilbert says, it's like an immune mechanism, a psychological immune mechanism in a way.
right. Well, so right.
I
I
mean,
think the
it's a way of coping with the vicissitudes of life that are painful or perceived as injurious in some way.
right.
I mean, I don't want to put words in your mouth. I'm trying
Right.
to.
Well, so I sort of think of grief as the response, and adaptation as the thing that has the sort of purpose of getting us back on track. The things that we do to adapt, the thoughts we have, the feelings we have, the behaviors we do, the social engagement, all that, the spiritual side, it helps us get back on track so that we can live a meaningful and satisfying life with, feelings of promise for the future.
And so, in a sense, the goal is to, have live through that experience, but have as the optimal psychological outcome.
Right.
Um, okay, so this is a little bit of a provocative question. Um, Currently, there's a reconsideration of the potential therapeutic uses of psychedelic drugs, and from things ranging from treatment refractory depression to PTSD to substance abuse and addiction, um, end of life care and palliative care. Is there a role in prolonged grief?
Well, I think that person is not the only one thinking about that. I can say that. In fact, our colleague Naomi and I worked on the multi-site study. One of the people we worked with was Sid Zizuk out in San Diego, maybe because he's in California, I don't know, but he is very, very interested in that question. He's currently doing, I believe, a study of psychedelics in depression, and we've seen that there have been some promising results from that around the world, maybe especially in the UK. But anyway, he I think when COVID is over, he wants to do that study. So maybe he'll come and tell you the results of it in a few years.
Or maybe you'll initiate it as well if you want to.
Yes.
There's
Yeah.
two of our faculty are currently engaged in studies, one in depression and the other in addiction. Elias Dakwar in addiction, and David Hellerstein in depression.
Okay. Well, I know David for a long time, and maybe we'll talk about some collaboration with this population.
Right. So is there something that well? So let me just this is my question now. If you're a clinician and you're treating somebody who sustains a loss, or if somebody comes to you after having sustained a loss, um, what would be the, I guess, these are the DSM criteria for prolonged grief. Can you summarize them?
Well, really, um, the DSM criteria really say that the person has to be experiencing persistent, intense grief, which is characterized by intense yearning, longing, and preoccupation with the person who died, or preoccupation with the person who died. But it usually is all, it's all of a package for a period of time that's longer than expected by their sort of social context. And that's, there's still a debate. I think in DSM, I think they say it has to be at least a year. And in ICD-11, they're saying 6 months. There's still a lot of debate about that. Different kinds of losses probably normatively sort of are intense for longer periods of time. But I guess really, I think after about 6 months of time, if people are still kind of not moving forward, and if you are finding the presence of those derailers, especially if they're center stage in the grief, then that person will almost certainly meet criteria for for prolonged grief disorder.
What is your view of the kind of controversy that occurred with the removal of the depression criteria, or grief and the depression criteria?
Well, I was one of the people who was in favor of the removal of of the the 3 months. It was, you couldn't diagnose depression in DSM-4 for 3 months after someone had died, and that didn't make any sense because grief is not over in 3 months. So if you're worried about the possibility that you're
Confounding it.
confusing, yeah, then that's not long enough. It should be at least a year, maybe longer than that. And so that didn't make any sense. And then the other thing is that there is some data. It's not a huge database, but there is data that early depression in the first couple of months. First, Sid again did a study of widows in the San Diego widows back in the 1980s, I think, and they found only 20% of them at 6 weeks after the loss. Only 20% of them were experiencing major depression the symptoms that met criteria for major depression. Everybody is feeling sad, but it doesn't meet the criteria for major depression. And there is some data from Denmark actually that says that if you don't treat that actually depression, I think 2 to 4 weeks after a loss predicts complicated grief or prolonged grief disorder 18 months later. If you don't treat it, it's going to predict. So it's going to be a kind of derailer itself. And you can imagine that that would happen because someone who's in the middle of a major depression is not really so flexible in their emotion regulation. They're not very, they're going to have a deficit of positive emotions, which is very important. And we think positive emotions really need to play a role in coping with anything, really. It's part of where we get our psychological, again, flexibility, creative problem solving, etc.
So are you saying that in the aftermath of a death of someone's loved one, while they're presumably mourning, if they meet MDD criteria, that it would be indicated to treat them, or it would be feasible to treat them pending level of severity.
Exactly. Was that a question? Or I mean, that's what I'm saying. Yes, that you should,
So
you should
you're not
diagnose it. Yeah.
not restricted from it, but it is a clinical judgment.
Yes, absolutely. It's a clinical judgment.
So here's a question. Can you say a little more about the relationship that a person has to the decedent and how that predicts complicated grief? For example, are parents at higher risk than siblings and spouses and so forth?
Yes, it does seem that the loss of a child, so the loss of a young person, in general, seems to be related, whether you're their parent, their grandparent, probably their sibling. We know a little bit less about siblings, but it does affect siblings quite a lot too. So the loss of a young person is a risk factor, and the loss of a spouse is not as great a risk factor, but also a risk factor. It seems like the sort of hierarchy of risk is first child or young person, then spouse, and then other close relationships, parents. Or in our older adult study, actually, that we did a few years ago, we were very surprised that about a quarter of the people who we saw actually were grieving the loss. These are older people grieving the loss of their own parents, had prolonged grief disorder. So people get it after anyone dies, but it is especially difficult. The deaths that are, um, I think you would naturally know, or more difficult are the ones that are more difficult and more likely. They're sort of risk factors.
Um, do you find any efficacy difference in using PGD virtually as opposed to in person?
Well, we don't have a formal study of that, but a lot of our therapists have been doing virtual treatments, partly because there aren't that many trained CGT therapists around the country. So a lot of people have been doing those virtually with a lot of success. So it is something that we know can be done. Um,
No reason to think it's any less effective as yet.
right. There's no reason to think it's any less effective.
So if somebody appears to be grieving for a loss, but it may be also associated with PTSD because of the nature of the circumstances that cause the loss, can PGT kind of distinguish that, or does it have broader efficacy that might be helpful to PTSD as well as grief?
Well, sort of back in the 1990s, when we were first sort of getting to know this condition, we called it traumatic grief, primarily because its symptom profile really mirrors PTSD. In fact, we said that we originally thought that it should be categorized as traumatic distress and separation distress, sort of the combination of traumatic distress and separation distress. And for that reason, CGT was developed in collaboration. Actually, one of our main consultants was Edna Foa, and so it originally sort of married IPT and PE for PTSD, but the procedures we use are very similar to PE. We did modify them. They have a slightly different purpose in PGD, but so that said, someone who really is mostly anxious and fearful around possibly dying themselves or somebody else dying, I mean, might really be better treated for the PTSD aspects first. I mean, so it's again a clinical judgment, and sometimes PTSD treatment is still a little different, even though they're quite similar.
Right. So if you're in let's say an automobile accident and your family member dies and you survive, you're dealing with both. So this is the last question, and it's kind of a sort of the trick question. Um, when couples that have been long married, when one dies, there's the pattern of the surviving spouse sometimes being more at risk for dying in the kind of immediate aftermath, a year or something. Presumably, it's related to grieving and how it impacts, physical resilience and so forth. But there's also another phenomenon. You could call it not a flight into health, but a flight into another relationship, where after 40, 50 years of marriage, there'll be one spouse will die and the other spouse, after the funeral and everything, and while in the grieving, within weeks is engaged in intense other romantic relationship. Is this a derailer? Is this a denial? Do you have any sort of, is this something that's been observed and you have any understanding of?
Yeah, I think it's definitely observed. I wouldn't call it a flight into health or whatever. I wouldn't call it a flight into anything. I would say that it's one way that sometimes people deal with the loss of a loved one, and there are many reasons why that might happen, but I would say that in general, it's thought to happen more so with men than women, and it's not necessarily unsuccessful. It's not necessarily a bad thing. It's or a dysfunctional thing to do. And
Yeah.
I mean, I know personal stories of people who've, one of them was a man who lost his wife, and a woman came to sort of his house um, after like a shiva or something after after the death, and they struck up. She didn't really know him very well. She was with a friend or something. She came to just kind of pass by, and they struck up a conversation. He was for some reason interested in her. Within 2 weeks, like you said, they were dating, and they eventually got married, and 10 years later they were still together and very happy. So that's a kind of story that is not unusual.
Okay. Well, Kathy, thank you very much for a wonderful presentation and discussion. Thank you, everybody, for listening. Next week, as I mentioned, Jonathan Torres on digital technology. And in the meantime, stay healthy and stay safe.
Thanks for having me, Jeff.
And talk to you later.
Okay.